Okay, so we're going to look at now how we can actually use this formulary file for our research, right? So I'm going to use the example of a new hepatitis C drugs. So in summary, then the formulary file gives us information on drug formulary, right? So which means that what drugs are covered and also what each drug and which tier in each drug belongs to, and whether any utilization management tool is applied to or not. So it's not all entire drugs in PDF files, but I would say most of the drugs that you might be interested in will show up in this formulary file. Now, as Stephanie said, that you can have this the researcher identifiable formulary files from 2010, then you might wonder, well, then what happens in 2006, between 2006 and 2009? And for those who are using earlier years of data, so this information on utilization management or tier ID was included in PDE file. So in drug event file, you have this product service ID, right? So then you didn't have a proper formulary RX ID there, but you had a tier ID and then prior authorization and step therapy and quantity limit. And now from 2010, CCW began to create the separate formulary files. And then you may ask and say, why, I mean, then now you have to merge, and why do we just keep those variables and that this formulary information in PDF file? So but if you think about it, if those variables are included in PDF files, you can have information only on drugs used by beneficiaries or the sample in your data. So if you obtain 5% sample, then you will get only the information on formulary for the drugs that are used by 5 sample, or if you have only, well, yeah, something like this. So formulary file is, I think that this is a really valuable file because it gives us information about the universe of Part D drugs and overall Part D plan general benefit generosity. Right. So actually, as soon as I hear about this news, oh, we will have a new separate formulary files, and something to say, oh, we gotta use this for study because it's a very rare opportunity that any researcher has to formulary information. And you guys probably use some commercial data sets, and then now data are getting better and better, but still the information on the drug formularies is not available. But CMS released this one to the public and for researchers to improve a program and for the beneficiaries, the service use. So it is a really good opportunity to look into. So how actually drug plans actually make decision on their drug formularies. All right, so how we can actually use the drug formulary files. So first you can link formulary files to plan characteristics file. Then you can actually look into how the variation in use of utilization management tools for each specific drugs across the plans. Or do MAPDs use more of these tools, or what about standalone PDPs? And also you can now you can also see the tier place, what tiers they're using for each drugs, and what how much cost sharing they charge for each drug, and how that varies across plans. Now, another similar to plan characteristics file, these formulary files are the same for all researchers. So these are really separate, independent, complete files. So it's not limited to the plans serving beneficiaries in your own DUA. So this is not this is independent on DUAs. Right, so now you can also link formulary files to PDE or drug event files, and then you can see in a way that you can simply control for this utilization management variables in your regression models. Or you can actually examine what's the really relationship between this imposing this utilization management tools and drug utilization. In other words, if the plan puts drug under prior authorization, are beneficiaries less likely to use that drug? And you can actually analyze that in using by linking formulary file to PDE. Right, so now we're going to look at some applications. Again, this is new hepatitis C virus drugs. Now you're becoming expert in HCV drugs. So this particular new innovative HCV drug groups, and these drugs are highly effective, but highly expensive, very expensive drugs. So new HCV drug Sovaldi came in December 2010 with a list price of $1,000 per pill. And two additional drugs entered the market in 2014, Harvoni and Bikirapet, but they actually had a similar prices, almost the same prices. Competition didn't help for these drugs in the early years. Now we have actually more drugs, and I think the price have probably gotten lower a little bit. Now, and so for these new Hep C drugs, payers charge really high cost sharing. So this high list price tag and high cost sharing caught the attention of media and policymakers and researchers, and it actually ignited the whole national debate over how much you are willing to pay for innovative drugs, right? So and then so once these were actually in the every single day, I was actually finding some news articles on the Harvoni or Sovaldi and Bikira. So I began to wonder, hey, how did this Part D plans actually cover these drugs? Like how much they charge cost sharing, or do all Part D plans put this on the specialty drugs and etc. So I was wondering about what is the coverage for these drugs by Part D plans, and is there any variation in that coverage, right? So then somebody might say, what do I really coverage, right? So not just whether it's covered or not, it's just one simple question, right? But besides that, you can actually look into different aspects of coverage. The first question you could ask is, well, how many plans or what percent of a Part D plans place specific this new Hep C drugs in a specialty tier? And also you could ask, oh, how many plans, or do all the plans apply prior authorization to Sovaldi or Harvoni? Or what about quantity limit? And also you could ask, oh, what is really average out-of-pocket spending on the patient side, right, to complete course of a treatment? So we looked at yesterday, these drugs requires 12 weeks of treatment. So then you can actually calculate, oh, then how much patient should pay in total to complete their course of treatment. So I wanted to look at these aspects, and then I performed all the analysis separately for PDPs and MAPDs. Now, questions for you. What data set do you need in order to look at this? Well, this is actually research question. This is all you want to know. Okay, what percent or how many plans use a specialty tier for Hep C drugs, and how much out-of-pocket spending? And do they use prior authorization or quantity limits? To examine these questions, what data? Oh, I didn't mean to show this. Okay, so what data sets do you need? So this information, this utilization management tools is, yes, Part D plan characteristics file. So somebody answered the plan characteristics file for sure, because you can get the cost sharing information, right? And also we have right, somebody answered characteristics file formulary. Okay, I have a question. Yes, we do need a formulary file in order to get the information about tier assignment and utilization management tool. And we need plan characteristics file to get the information on cost sharing. My question for you, do we need a PDE file? Somebody says we might need the PDE event file, but do we need a PDE event file? What about MBS file? Do we need a medical beneficiary summary file for this study? PD is a drug event file, right? No, right? So we really don't need to get into any of a beneficiary level or drug event level. So this is a purely plan level analysis, right? So each file costs $1,000, I can tell you. So if you get just these two files, then you can actually do a study. And that's what I did, right? So what is step one? What did you do? Now you have this formulary file and plan characteristics file, and you want to answer this question. What's the first step? How would you go about? Okay, so let's specify, it's like we already defined the drugs that we are interested in, right? We have 3 drugs that we are going to look into: Sovaldi, Harvoni, and Bikirapac, right? So we want to, and then first we want to know what tiers each of those drugs belong to for each specific plan or specific formulary, right? So the first step you want to do is using this is a formulary file, right? So you have this brand name information here. So using this brand name, I would select all the records for those drugs from formulary files. Then you actually select only you. In other words, what I'm saying is that you are interested in formulary information about only for those 3 drugs, right? So you simply use this brand name information, and then just select the records of new Hep C drugs from formulary file. This is the example. I probably made up the numbers, but this is how it actually looks like. Now I just select the 2 formularies. So these are formulary, which is 889. So these formulary covered all 3 drugs: Sovaldi, Harvoni, and Bikira. You can see that this formulary has Sovaldi RX ID is 1738, and Harvoni 1739, and Bikira 1740. So they covered all these 3 drugs. What about this formulary 888? This formulary did not cover Bikira. So this formulary included only Sovaldi and Harvoni, right? And they have the same formulary RX ID. Oh, okay. And then you can see here, oh, they are using different tiers. And oh, they are applying, just use of a prior authorization is different depending on formulary, right? So then now the question was whether these plans put these drugs in specialty tier or not, but we don't have a specialty tier information from formulary files, and we don't have a cost sharing information either, right? So where do we get this information? We need this information from plan characteristics file. So then the step 2 is now we need to link this formulary file to plan characteristics file. Ah, that's fine. What is really linking variable? Why this is show? Just ignore this one for a while. So what is really linking variable here? We have a formulary file that has a formulary ID. That's it. Formulary file does not have a plan ID or plan characteristics, the contract ID, right? Contract ID and plan ID. So the linking variable here is a formulary ID. So each Part D plan has one formulary, okay? But one formulary, the same formulary can be shared across by many plans, right? So formularies, you see here, number of formularies are 557 in 2021, but we have more than 5,000 plans in 2021. So a lot of plans actually share one formulary, right? So, and this formulary ID is not unique to that specific plan. So you have to do here many-to-many merge, right? So once you, okay, let's move. This is what you see once you actually merge formulary file with plan characteristics file. Now, so plan here, so now you can see this in the plan file, it's usually the one record, one line represent country ID and plan ID, but because we actually attach the formulary information which has the 3 drugs, you will actually observe 3 lines for each plan, right? So for this plan, now we have a plan ID and the drug information that we got from our formulary files. Now, from here, we need to add specialty tier information and cost sharing, right? So I first actually merged this with the plan-based file, and then we have this contract ID and plan ID and tier ID, and then I'm going to merge with cost sharing tier file where the unit of record is contract ID and plan ID and tier ID. So then you can get the cost sharing information and specialty tier, right? So what happens is that once you get this cost sharing information, cost sharing and tier file, you will have a specialty tier yes and no indicator for here. So if it tier ID 03 is a specialty ID, the specialty tier ID, you will see Y here. Then you know that, oh, Sovaldi is placed in the specialty tier for this plan, right? And Harvoni is placed also in specialty tier, but Viekira is not. That's how you get to actually add this specialty tier information. And then you can also see the corresponding cost sharing information, right? So once you have all this information, now we need to analyze. So when you analyze, I would actually analyze for each plan. It's a cost sharing tier file, another file different from plan characteristics file. This is one of a sub plan characteristics file. So plan characteristics file is just refers to 6 different files. So once you order a plan characteristics file, you will receive 6 different files. And one of them is cost sharing tier file, and another is a base plan file. Now, and then so once you have this information, you look at this record. So now my question was, how many plans you use specialty tier for Sovaldi, and how many plans you use specialty tier for Harvoni? So we're going to actually analyze drug by drug. So you can simply select from your data set, select Sovaldi, and then do an analysis, and then select Harvoni, and then select Viekira. And then you can get this information just from the data sets you already created, right? And then the final step here is you need a little work here. You want to calculate the total out-of-pocket spending based on cost sharing type and the course of treatment. This is easy. It's all 12 weeks treatment. And usually cost sharing information is for every 4 weeks. And then you're going to have three fees, right? So 3 times for 4 weeks of treatment for each fee. And then if it's a co-payment, it's easy. If a co-payment for 1 month of data supply, then it's going. If it's $100, it's total out-of-pocket spending needed for the course of a treatment is $300. But if it's a co-insurance, you have to convert that into dollar terms. You have to multiply your co-insurance rate to 25% or 30%, multiplied by total drug spending, right? So, and once you do that, this is what I got. This is a very simple process, right? So you just create the data sets you need, and then you can simply do some descriptive data analysis. So Sovaldi was covered by 100%, whether it was MAPD or PDP. Oh, but Sovaldi, do you see here? Prior authorization, yeah, 100%. They always required the specialist specialist prescription or some authorization or some explanation and why this patient needs Sovaldi. Viekira is covered by only 30% of this Part D plans, whether it's MAPD or PDPs. And quantity limit, they are more likely to use for Sovaldi and Harvoni. And almost or over 95% of plans put these drugs in specialty tiers, and almost all plans use the co-insurance. But you see, this is 99.9%, which means at least one or a couple of plans did use co-payment for Sovaldi. Now you can think if someone needs Sovaldi, probably that beneficiary wants to actually find that plan, MAPD plan that uses co-payment for Sovaldi, right? So, but this is just it's simple analysis, but it's a very informative, and it's actually it works as one paper. Okay. Now, right. So you can do, and this is total out-of-pocket spending required for the course of treatment. See, you can see it's pretty similar. As I said, the prices were pretty similar across the drugs, about $84,000 or $90,000, and total out-of-pocket spending needed is for non-LIS enrollees, and it was about $6,000. I don't see much differences between MAPD and PDP for the mean values, but you can see large variation among MAPD, right? So you could actually see some MAPDs, you need only $2,000 or $2,600 to complete the treatment. But if you are in PDP, you essentially need every beneficiary in PDP plans need $6,000, more than $6,000. So you can easily apply these things. Now you can think of any other drugs that might be more really expensive or innovative, but some other unique aspects to look into, then you can apply similar analysis. You can use only formulary file and plan characteristics file. So I'm going to look at very briefly another example using specialty cancer drugs. Yeah, this is a little bit older. There is 2010 and 2012. So this imatinib, right, Gleevec. This is leukemia treatment. Back then, it was a brand name drugs. Now generic drugs are available for Gleevec. So for Gleevec, and the Epoetin is this treats anemia that you may have when you are on chemotherapy. So oftentimes those who use chemotherapy, that they use Epoetin. And this is expensive as well. Not as expensive as Gleevec, but it's expensive drug as well. So for these two drugs, the plans placed this each drug in a specialty tier was about 2,000, more than 2,000 plans out of 3,000 plans. And this is just the opposite, the plans that didn't use a specialty tiers. Now, and then you can actually also get cost sharing information. So most of plans, among those plans that placed Gleevec in a specialty tier, almost all plans, except for plans, they used a co-insurance. But look at this, for even Gleevec was, back then, it was the monthly total cost was $5,000, but then they used a co-payment, only $75. I think it's a couple of MAPDs. But when they didn't use, and any plans didn't use specialty tier, you can see similar, even though they didn't put in the specialty tier, they also used the co-insurance. It's even larger variation. They probably must have put this Gleevec into non-preferred drugs and then charge 75% co-insurance. But on the other hand, some drugs use the co-payment, only $30. And you can see this is huge variation for non-LIS beneficiaries. Similarly for Epoetin, some plans that place the drug in a specialty tier, they usually use co-insurance, about 30% of co-insurance. No plan used co-payment, but for when they didn't use a specialty tier for Epoetin, about half, a little bit less than half of plans actually used co-payment. This is pretty decent co-payment amount. Now, so how do we use a formulary file for our research? You can link formulary files to PDE. Another example is, so far we have used only plan characteristics file, but now you can actually link a formulary file to PDE file. Then here actually you can examine drug utilization, right? So what's the relation between plan benefit generosity and drug utilization? So I asked the question here, does cost sharing for specialty drugs? These are expensive drugs, but they might be really effective. But charging high cost sharing for specialty drugs, does it influence use of specialty drugs? Here I looked at uptake of any specialty drugs, and I looked at this in a cancer for cancer patient. So I constructed this initial cost sharing measure using only formulary files and plan characteristics file, and then I merged it to the PDE file, and then looked at whether any patient with cancer use any specialty cancer drugs. And here you can see as the cost sharing increases, the probability of taking up or using any expensive specialty cancer drugs becomes decreased here. Right. So the idea was that there was some discussion here that while this cancer patient, they have really debilitating and serious conditions. So does price matter or not? To these patients, even though the drugs might be expensive, they might still use it. But we here found that even just a $100 difference in cost sharing, the probability of filling the prescription for cancer drugs that actually decreased. So that's what we found. Now, again, this is now a summary that this, what is that? No. Here, yeah. So one thing that I want to actually comment here that is, so if, what is what's going on here? I'm sorry. So what is, some people use that, well, okay, we know that, but we don't have this sort of formulary files for commercial database, and so some other cases, or some people may not actually look into this even for Part D, the drug formulary files. But we do have information on cost sharing in PDE file, right? So we covered this patient pay amount. So what if we just construct cost sharing measure using PDE files? And I want to really give a caution on that and discourage you from doing so, because when you look into cost sharing information, you want to examine the impact of a price on quantity. But if you measure cost sharing using PDE file, what you're doing is you are constructing your price measure based on quantity. So it's a dual causal. You look at the impact of price on quantity, but your price is constructed based on quantity. So you won't be able to get actually unbiased estimates, or you won't be able to get isolate the impact of the price. So because since we have now formulary files for Part D plans, so I really highly encourage, I strongly recommend you consider using formulary files if you are interested in any cost sharing stuff. Right. So, okay, which variable did you use for your IV in this study? Is there a link to it? I can send you a link later for this paper. Because we were looking into cancer drugs, we used the drug formulary information for other drug classes, I think.